there are 20 questions. Please write down. There are no negative markings, correct? No. So this is a high value question. If you get it correct, you may get 4 marks, 2 marks. Huh? High net worth. There is a very nice word in Hindi, sir. Tukka. Tukka man. You cannot bullshit. Negative marking nahi hai, sir. Okay, we have, I think at 18, please start collecting the answer sheet, somebody. Yeah, after 1 minute, please start connecting the answer sheet. So 2 minutes, please check, fill up whatever you want to do. I have a very high possibility that on that row, 3rd and 4th row will get the prize. Everybody is going to they have had a lot of discussion. So is anybody ready to give back the answers? Answer sheets? In 30 seconds. 30 seconds, you start collecting.
Ladies who are collecting the answer sheets, just bring them over to the dais and hand it over to us.
It's a very simple question.
Dr. Rajat Ghosh, please come to the dais and start helping us as you do every year.
They are going to check. Answers I will discuss now. Everybody has given the papers? Everybody has given the papers?
Have all the papers been collected?
Okay, once I start giving the answers,
No more.
we
more
will not
papers
take
be
any
taken.
papers.
No, Shantanu, start giving the answers once the papers reach me.
Okay. All collected? Once I give the answer, nobody will take it. Okay, can we discuss the answers? Dr. Mohan sir, answers bata दूं? सबने दे दिया? Okay, we are not taking any answer sheets now. Okay, the first question was, which month is celebrated as Medical Ultrasound Awareness Month? It is the month of October. So the ASC, we all follow standards. I don't know, in India, we don't have any standards, but the American Society of Echo in JACE 2019 have now started celebrating October as Awareness Month. Maybe we should do something in India. So, Dr. Satish, we can think about it at the IAE. But as of now, it is being celebrated in the month of October. So this was the second case, this little case 1. The answer is 2D speckle tracking. Correct? It is very easy. So from one image to the second image, you are getting the strains, and this is a 2D strain imaging which is being done.
If someone answers strain.
If somebody answers strain, that's fine. We'll give it. If somebody has not written 2D, then also we'll give it. Lenient hai, sir. Aap 20 after 20. Strain is fine.
Do all the answers have, all the questions have the same value, or?
No, I think 1, 1, 1, all.
No, what we are doing, we are giving 2 marks per answer. If, like in the 4th question, there are 2 parts of the answer.
Strain can be color strain, can be anything strain, sir. Let's
Some,
make it 2D speckle. This is speckle tracking, sir. Speckle tracking. We need speckle tracking. Imaging is also fine.
so let's be a little lenient.
If somebody writes strain, is it
We
fine?
give him 1. We give them 1. 1, that's 2, half of 1.
I agree with Dr. J.C. Mohan. Every answer is 2 marks. If he writes strain, he gets 1 mark. if he writes 2D speckle tracking, complete mark. Correct, sir? Yeah. So this is a 2D speckle. We are using the speckle. The concept of speckle is being answered. The next question, what was the transmitral flow pattern? The answer is in the ECG. The answer is in the ECG. It is first degree AV block. Now they are sound. So the importance of this imaging was always have an ECG whenever you are doing a Doppler. Yeah, I can. I was. Correct. Sir को एक mic दे दो. Okay, so we need first degree AV block with fusion. Sir, आप mic ले लीजिए. Yeah. Next, the fourth one. This was easy. Normally, the lateral annulus velocities are more than medial annulus, but in constrictive pericarditis, it gets reversed. So the velocities of lateral becomes lesser than the medial. So we need both the answers, sir.
So if one writes only constrictive pericarditis, one.
One. We need annulus and constrictive, both. Right? We were knowing about this? Right. This is dimensionless index. No confusion. 2 marks. If the answer is index, 0 mark. If the answer is dimensionless, 0 marks. It has to be both, correct? Okay. The next question was, what is the LV filling pressure in this case? And why is it happening? There is diastolic MR with markedly raised LV and diastolic pressure. We need both the answers. Dr. Mohan, you want to explain?
No, it is
It's very
true
easy, but yeah.
that there is no forward flow during early diastole. There is backward flow.
Yeah.
It actually tells you that the ventricle is not sucking the blood. Why it is not sucking the blood? Because its own pressure is so high in early diastole that it's sending the blood back to the left atrium. So the markedly elevated left ventricle diastole. And of course, only during atrial contraction forward flow occurs, which means only during atrial contraction left atrial pressure overcomes the left ventricle diastolic pressure. And of course, you do have only early systolic MR, another early systolic MR, or which is during IVCT as well as early systole actually. And this itself, and this is not a, what you call pan-systolic MR. This actually also is indicative of valve actually remaining open, and we think it is also actually MR, that is true, but it is also representing raised diastole once the atrial contraction has ended.
Yeah, so I think what he's trying to say is normally the MR is systolic, but if you start seeing an MR in the phase of diastole, early diastolic MR, there is a raised...
See, the important thing is this patient has left bundle branch block.
Correct.
In left bundle branch block, the systole will start much after the QRS complex. So what is happening during QRS complex is actually the late diastolic mitral regurgitation. So patient has early diastolic mitral regurgitation, late diastolic mitral regurgitation, and so the diastolic pressures are significantly elevated in all phases of diastole, barring during phase of atrial contraction.
Okay. This is a specific sign of aortic regurgitation. Diastolic flow reversal if we put a pulse wave Doppler in the descending thoracic aorta. This is a book picture showing that if you put a pulse wave Doppler in the descending aorta, normally there is a forward flow, but if you have a reverse flow in the phase of diastole, specific sign of AR seen in suprasternal view. Yeah. This is a classical picture of HOCM, when there is peripheral vasodilatation, either by Valsalva or you can use a nitrate, increasing the gradients in a patient of HCM. So 33% of patients.
Probably those who write HOCM, you have to think carefully. How do we justify giving better marks to those who say this is dynamic intraventricular gradient
Correct.
as a result of hypertrophic obstructive cardiomyopathy?
We'll give 1 mark extra.
Pardon?
They get
Okay,
3
you
out
can
of 2.
Yeah.
You can think
You
of
can
which
do.
way to give.
So I want to tell you 33%, it is one third. In HCM, 35% will have at-rest obstruction. 30% of patients will have no obstruction, but 30% will have provocable obstruction on provocable test. So the provokes which you can do is Valsalva, amyl nitrate and all those. Right, sir?
I like the lobster claw.
Correct.
This is what is typically described as the lobster claw.
Yeah.
Can be seen in hypovolemia
Hypovolemia
also.
also. After dobutamine challenge also, a lot of patients. Correct. Ninth case, this is a normal LV muscle band, which you often see in normal persons.
So both answers will be correct. If you write false tendon, I will take that as correct.
Correct.
Anomalous muscle bundle, that also will take.
Yeah, false tendon, muscle band, these are all LV. One guy has got 2 answer sheets, so he's playing a lottery, sir. जहाँ पे ज़्यादा मिल गया वहाँ पे ले लेगा वो. So the point
There is
is,
a question. I have got an answer sheet on which it's written Elvis with a phone number and an email ID, which doesn't match with the next answer sheet, which is also Elvis Senthil. Are they same person? Who is Elvis Senthil? Good. And who is Elvis with a blank answer sheet? Or somebody got 2 answer sheets by mistake?
forget the answer. अरे फिर से बंद पड़ गया. Okay, I don't know what's happening. I think he must have taken it earlier. Why it is closing? Okay, so we had the next patient coming with syncope. Can you show? This was hydrated, multiple hydatidosis.
Liver and lung probably also.
Yeah. I'm sorry there was no ECG in this. We should have an ECG. Why was this patient hemodynamically unstable? This is a vegetation. Yeah, we got this right. People are happy. Yes. This was easy. Coming to 12th.
So the question is, should you give full marks for somebody who says infective endocarditis as answer? Hemodynamic
Right.
instability. Hemodynamic instability is acute MR or
Acute-
acute oblique
causing
subacute MR.
severe or acute MR.
Yeah.
So we need infective endocarditis with acute MR. Why he's unstable? It is dirty, sir. It is unlikely to be flail. It's a dirty mass. Sir, what do you think? It's an eye. See, there are vegetations here, sir.
No, one could actually ask for more views,
Those-
one could
yeah, this
talk about
is-
differential diagnosis, but the correct answer is there actually, so we should.
Acute MR due to infective endocarditis
See,
possibly.
remember in life, sometimes you are given a single choice and you have to make best of it. Sometimes you are given multiple choices and you become wiser and you say, okay.
Probably some caudal rupture also, no?
See, I don't know about that. Well, it doesn't affect me now that I am a widower. It doesn't make a damn difference to me.
Okay, let's move ahead. This is an imaging artifact and it's called side lobe artifact. So this is the, see, many times you see a horizontal artifact kind of line which is created. So this is the artifact which is getting developed because of the AR. So this is called a side lobe artifact. We have up, yeah.
Students answer, why is this not MR? Why is this an artifact? Why is it not truthful MR? Because AR is a dazzling phenomenon. MR is a sizzling phenomenon.
And also the direction of the flow. You can see the direction of the flow. Several things are there. Right? So the artifact is a separate chapter. You should be all knowing about it. This is side lobe artifact. This is very easy. A scorer, apical cardiomyopathy, nothing.
Why is this not reverse Takotsubo's?
Because the bases are contracting.
Contracting.
They are not paralyzed.
Yeah, okay. Differentials.
I would have thought the closer differential diagnosis would have been EMF.
EMF.
LV EMF.
EMF could have been, but this is apical.
Oh, there is no fibrosis. You don't see much of fibrosis. You just see the normal endocardium. Yeah, you can keep second possibility. If somebody gives apical cardiomyopathy, I'll give 2 marks. If endomyocardial fibrosis, I'll give 1 mark.
Sir, no. Whenever the referees are debating, the quiz master decision is final. It is apical. So it is apical cardiomyopathy. Yeah, we can always debate.
How to think beyond what we are seeing. Actually, if you look at the tip of the apex, in endomyocardial fibrosis, the apex is blunted. Here it is a typical spade shape.
Spade shape.
So you do not think of,
I would respectfully disagree. That left atrial enlargement is typical of endomyocardial fibrosis.
this one.
Yes. So look at the amount of left atrial enlargement.
LA margins is different.
No,
sir.
that's what I'm trying. When you look at the left atrium, it tells you that think of EMF. Don't think of apical hypertrophy.
No, I
cardiomyopathy.
said yes, that is one of the closest differential. Before you said it, I said it was endomyocardial fibrosis.
But sir, isolated only they affecting the LV without affecting the
Yeah, it is described.
It is described.
It is very well described.
Originally, when this was, I think it was Dr. Vedalingam who described 10% of all cases or 11% had isolated left ventricle cardiomyopathy.
But this is a close differential.
Yeah, correct.
I
So
must
this is apical cardiomyopathy. Yeah. The next one is, this is a tissue Doppler showing 555 sign. Means what? So once you put a tissue Doppler at the medial annulus or lateral anywhere, the velocities of E prime, A prime and S prime are all either at 5 or less than 5. It is associated with poorer prognosis, mostly seen in restrictive patients or like restrictive physiology patients like amyloidosis, restrictive cardiomyopathy. 555 sign.
You can see the image above. It shows you biventricular hypertrophy, pericardial effusion, and granular speckling appearance. We know that this is a case of cardiac amyloidosis having 555 sign, indicating combined systolic and diastolic dysfunction of the left ventricle.
We need 3 5s to get 2 marks. 2 5s मिलेगा तो नहीं देंगे.
No, if somebody knows the sign, they would have written 555.
Complete.
If they don't know it, they won't write 5-5.
Right?
Actually, over a period of recent times, people have become more sensitive to diagnose and find out whether it is amyloid or not. Because out of all the restrictive cardiomyopathy, probably this is the only type, the TTR variety, which has some light of ray for therapy. So it's...
Yeah, so this was the M mode across a St. Jude's metallic valve. It is a metallic valve showing a normal opening. You can see the reverberation. Bileaflet valve, 2 leaflets can be seen, and you can see the reverberations across the whole of spectrum. M mode showing a bileaflet metallic valve.
So how do we give points? Because there's in mode 2 prosthetic valve.
I think we can give points if someone says.
letter called M mode prosthetic valve.
metallic.
You need metallic word. You cannot have biprosthetic.
No, mechanical.
Mechanical is fine.
Mechanical valve.
See, the important point is that you are no longer doing M-mode echo prosthetic valves, but this gives you a lot of clues. Reverberation, one aspect, opening in diastole, but look at the corners. Closing and opening corners are sharp. They are not rounded. Rounded will tell you prosthetic valve dysfunction. But when they are sharp, angular like this, that tells you that this is a normally functioning prosthesis.
The opening is there. That's very important.
If somebody has written DVR, give one more extra point.
DVR.
It is double valve
Yeah,
replacement.
it is a
It's a
double
double
valve
valve replacement.
That is true.
Okay. This is something which has recently been started. Tell you, it is transesophageal lung ultrasound. Yeah, people are happy. People have written. Okay, transesophageal lung ultrasound is now an entity where it is being used intraoperatively and gives a lot of information. B lines, A lines, lot of things. Okay. Am I supposed to end? Okay.
No, quickly just finish it.
Right, we'll finish off. This is TELU. We need the whole information. Transesophageal lung ultrasound. This is tricuspid valve, flow across tricuspid valve, showing TR jet velocity alternance.
So the correct answer should be low pressure TR with TR jet spectrum, flow spectrum alternance. The first important thing is, it is a low pressure tricuspid regurgitation.
The maximum pressure is going up, not even up to 2.
No, that is again, but the other point which is important is that you don't have the typical V cutoff.
V cutoff.
You know, and also you have, of course, TR jet which is alternating. That is true.
But if somebody has written the entity, when we get, do we give it? Or we need this?
I think complete answer, if for 2 marks, one has to write low pressure TR with TR jet alternance.
Correct. Next. This is Dr. Mohan had spoken. GLS or longitudinal strain, longitudinal deformation gives you subendocardial information, subendocardial contraction, while circumferential and radials are subepicardial. So subendocardial is the answer. And the last two,
We have got a lot of answers who have written global.
no, we need the subendocardial one. Sir, right? Subendocardial should be there.
So we have given 0 there.
Right. And the last is an important thing. What it means, so the A and B, the depth is going down. Once the depth goes down, 19th is frame rate and line density. Frame rate increases, line density increases. Spatial resolution increase, but the temporal goes down. Okay, so the first thing is, once we decrease the depth, frame rate, line density increases, spatial is improved while it decreases temporal. So first two is 19, second two is 20.
Temporal resolution decreases
Yeah,
with increase of frame rate.
I checked it. I checked in the book and checked with him also. I had a doubt. So how many must have got 20 out of 20? Or rather 40 out of 40?
My guess is 16 would be the maximum people would get.
How many of you got 0 out of 40?
16 is 32, 32 to 30.
The blank paper got 0.
Blank paper got it. Nobody got 0. That is nice. Okay. So that finishes. We have more questions but nobody will get 40. Achha, great. Okay. I hope this was slightly educative and a revamp of whatever has been taught since morning. And over to you, Dr. Dipankar Da. That ends. Yeah.
Okay, we are getting, we need more time to correct.
Correct. So we have one more.
Chandra, you announce the next session. Let the next session go on.
Yeah.
Yes, by the time the answer scripts are corrected and the participants keep on waiting for the prize to get, we will move on to the last session for the second day of our conference. And